73-year-old female, past medical history unknown. On October 1st, 2020, thunderclap headache followed by reduced level of consciousness. She was intubated on the same day and underwent external ventricular drainage on the next day due to hydrocephalus. She was transferred to our hospital on October 15, 2020. Neural examination at the admission. Ramsey sedation scale 6. No response. Isochoric and pinpoint pupils. This is her CT scan. Here on the right side, we can see acute blood on the lateral part of the pons. This is correspond to the right CP angle region. And here on the left, we can see blood on the anterolateral part of the CP angle over here on the right side. This is the posterior view of the 3D reconstruction of her CTA. Here we can see the right vertebral artery. This is the left vertebral artery. This is the basilar artery. We can see an aneurysm arising from the origin. Here, this is the PICA. So this aneurysm originates from the bifurcation, from the takeoff, the origin of the PICA that runs this way. And here we have still the posterior view, but a little bit superior posterior view. So once again, this is the right vertebral artery. This is the origin of the right PICA that runs this way. And we can see an aneurysm over here at the origin of the right PICA from the right vertebral artery. This is the lateral view from the left side. So this is the left vertebral artery. This is the right vertebral artery. We can see that the aneurysm is pointing up. So in the surgery, in a prone position, the aneurysm will be pointing forward. And we can see also here the distal. This is a proximal vertebral artery, proximal to the aneurysm, and this is a distal vertebral artery. So this distal part of the vertebral artery is pointing predominantly forward. So in the surgery, the vertebral artery in a prone position will be pointing downwards. And the proximal part of vertebral artery, proximal to the aneurysm, is pointing up. So in the surgery, in a prone position, this segment will be pointing anteriorly or forward. So we have to keep this in mind. And we can see that the origin of PICA is going laterally, so away from the neck of the aneurysm. This is what I'm expecting in the surgery. So the patient is in prone position. So this is basilar artery. We saw that on the angiogram that the proximal vertebral artery was pointing up. So in surgery, this is going to be pointing forward. The aneurysm was pointing up on the CTA. So in surgery, the aneurysm will be pointing forward anteriorly. And the distal vertebral artery, distal to the aneurysm, was pointing predominantly anteriorly. So in the prone position in surgery, the distal vertebral artery will be pointing down. So we have to keep this in mind. This is what I am expecting to find the aneurysm in the surgery. So once again, this is what I'm expecting to find the position of each element involved in this surgery. So the proximal vertebral artery, proximal to the aneurysm, will be pointing anteriorly, forward, because it was on CTA, it was pointing superiorly. So in surgery, in prone position, will be pointing anteriorly. Aneurysm was pointing predominantly superiorly, up. So in surgery, in prone position, it's going to be pointing anteriorly, forward. The distal vertebral artery on CTA was pointing anteriorly. So in prone position in surgery, the same segment will be pointing down. So this is the exposure after the dural opening. We have performed the right suboccipital craniotomy only on the right side, and I was standing behind the patient, so we can have this very good anatomical view of the medulla over here, right cerebellar hemisphere. Here's the spatula lifting the right cerebellar hemisphere. So this is the region of foramen magnum. Let's go to the video. So all the adherences has been cut. So I was able to lift the cerebellum. Now this is the vertebral artery. This is the lower cranial nerves. This is 11th spinal accessory nerve going to the region of foramen, jugular foramen. And here I'm dissecting. This is a 12th hypoglossal canal, beginning of hypoglossal canal. This is a PICA, lower cranial nerves. This is an old clot. This is origin of PICA going laterally. This is the proximal segment of vertebral artery going forward. Patients in prone position. This is the aneurysm pointing predominantly forward. Now I'm dissecting the neck. As we remember, in the prone position, the distal vertebral artery will be pointing predominantly down. So this is 12th, 11th, PICA, origin of PICA. And this is the lower cranial nerve. I'm applying a temporary clip. Be careful not to squeeze the lower cranial nerve. So, and now I'm applying the permanent clip, and we'll have to see at what level I can include the neck of aneurysm, not including the distal vertebral artery. This is the gap between the neck of aneurysm and the vertebral artery. You can see that. So I'm using a semi-curved clip. Now the clip has been applied. Now I have to remove the temporary clip. And checking if everything's fine. The aneurysm's been occluded. This is her postoperative CT scan. So we can see the extent of the suboccipital craniotomy was performed only on the right side. And as you remember the video, we cut all the adherences between the cerebellum and the medulla oblongata on the right side. And I was able to lift the right cerebellar hemisphere. So this technique is called the Transmedullary fissure approach. So we lift the cerebellum. We can go easily and reach the lower CP angle region. We can reach up all the way up to here. We cannot reach if the aneurysm the PICA aneurysm is located exactly at the midline. Then you have to use the far lateral, maybe transcondylar approach to have access to the PICA aneurysm that is located right at the midline. But up to here, the way we did, the aneurysm was located here. But even if the aneurysm is located a little bit more anteriorly, you will be able to reach this location using the transcerebellomedullary fissure approach. So what happened to her after the surgery? One day after the surgery, the sedation medication was withdrawn and she was fully awake and obeying orders 3 days after the surgery. But due to pneumonia, extubation was not possible and she underwent tracheostomy. She eventually passed away 3 weeks after the surgery due to respiratory failure.